We're your hosts,
Aaron Bacus
and Jason Kindler.
We like to sit down with our guests to hear their journey, their challenges, and how they impact the local community.
So grab a seat, tune in, and let's get inspired by Jacksonville's everyday workforce.
Welcome to Hometown Jax. Dr. Corey Duncan, thank you for being on Hometown Jax. I appreciate this.
I'm real happy to be here. Thanks for inviting me.
I'm excited because you're the first doctor we've had on the podcast. And I have to tell you, I've asked a few and they didn't really want to come. So I'm really happy that you're come and you're going to be here to talk about your journey as a doctor. I think it's super interesting. I've always had a lot of respect for doctors because I know how much studying you had to do to get that.
Yeah. Well, thank you very much.
Lots of studying, huh?
Yeah, it's a journey.
Yeah, for sure.
They say it's lifelong. You got to kind of keep at it.
Right.
But yeah, it's definitely, you got to hit the books pretty hard, pretty early.
I would think so. Well, let's go through your journey. So did you come from a medical family? What gave you the itch to be a doctor?
Yeah, actually my dad's a pipe fitter.
Okay, well, that's a little different.
Yeah, and I was one of those people in high school that I kept changing my mind about what I wanted to do, and I ended up studying biology with kind of a focus in zoology in undergrad. And there were some volunteer programs at Miami Children's, and I went one weekend to, basically we were just going into the pediatric unit for the kids that were not sick but having to be in the hospital for a very long time, and we would just play with them. And I kind of got interested, and they were like, well, hey, why don't you take the MCATs to see if you hit the prerequisites, and ended up taking the test and applying, and got into Florida State. I remember the date actually.
So did you go undergrad at?
I went to Berry University in Miami Shores.
Okay.
It's kind of a small,
Miami. Okay.
Yeah, kind of a small Catholic school.
Okay.
Not a big pre-med school.
Mm-hmm.
I think my graduating class for biology was like 20 people.
Oh, wow.
Yeah,
okay.
Very small, which was great because I got to do like a lot of hands-on research, but none of it was medical or clinical. Actually, actually got published in 21 for a cicada paper that I worked on.
Like the bugs?
Yeah. Yeah. I was part of the data collection team. We were like measuring the wingspan and stuff.
Interesting.
Yeah, it was really cool. And I got into Florida State. I remember I got the call on April 1st.
Okay.
And when the recruitment person called me, I was actually like at a restaurant with some friends, and I was like, "This is a joke. Somebody pranking me right now."
Did you apply to a lot of medical schools? Or?
I applied to maybe a dozen.
Okay.
Mainly in the Southeast. And I only really got into Florida State. I got waitlisted at University of Miami, but ultimately I think they talked to each other. And then once I had already started at Florida State, they were like, okay, well,
Right.
Yeah, and I already started there. Florida State starts earlier in the season than most schools. Most schools start like the typical August, September, but Florida State starts in May.
Well, was that a difficult football decision for you? I mean, man,
I didn't go
State,
to UM.
Miami.
my mom did go to UM, so like it kind of was a UM family. My wife went to UM.
Okay.
But no, I mean, Florida State is an awesome school. It's such a great community.
Yeah.
So like it was really, even though I have no regrets, I always felt so welcomed by the school. They really did a good job of
That's awesome.
taking care
Well,
of
my
us.
daughter and my wife went to Florida State, so we got a lot of Florida State in our house. So
Very cool.
That's awesome to hear. So you grew up in Miami, kind of got the itch going to some medical things and volunteering. So obviously you had that urge in your heart to help people. Is that right?
I think what drove me the most is I love talking to people. I love to, and what better profession to really know somebody at an intimate level than being a physician. And there's, you don't get a lot of opportunities in life to help people, and whenever you can, it's just such a privilege. And I just really like that aspect of it. Like you really get to meet lots of people from lots of different walks of life and lots of different situations and get to know them. And that was really what attracted me to being a physician and applying to medical school.
That's awesome.
And ultimately to primary care.
So let's talk about medical school, because a very select group that ever go to that, like, so how is it? Is it 4 years, and does it just get progressively harder? Like, talk about your life during that 4 years.
So undergrad is pretty, it's the same for most people. You have to hit a certain number of prerequisites in order to apply. Take the MCAT, the medical college admission test, and then you make your applications.
And MCAT, I'm assuming, is very difficult.
I joke. At that time, it was the most difficult test I had ever taken. It was about 4 or 5 hours long, if I remember correctly. Back then, I took it on paper. I'm kind of dating myself. And I took a test equally as hard in medical school every month.
Really?
From that point forward.
Interesting.
Yeah. So, and then when you actually take your boards, they're even more intense. So it's kind of, it does stepwise get more difficult. For example, like if you're a full-time student and undergraduate, you're taking between 12 and 18 credit hours, but you're usually taking 21 or 22 credit hours per semester in medical school. And they're in the semesters are summer, fall, spring. There's not usually a break. Sometimes there's one that first summer you get a break, but not always. It depends on how things are going.
Interesting.
And it's a lot of credit hours. They always call it, they say it's like drinking from the fire hose of knowledge. Just try to absorb as much as you can.
Right.
And weekly quizzes and study groups and just you have that block test, and everything is regimented where you have to take anatomy and physiology and pharmacology, and all the tests covers all the classes at the same time.
Wow.
So it's pretty intense, and you kind of just have to absorb as much as you can and keep moving. The first 2 years traditionally in most medical schools, at Florida State's a little different because they start exposing you to clinical very early, which is great and I'll go over that. But most schools, first 2 years, all sciences, all just background sciences. You take your United States Medical Licensing Exam Step 1 at the end of the second year, which is now a pass-fail, which is good. It used to be a graded. And then if you pass that, then you go into your third year, and your third and fourth year are your clinical years, where the third year is like your core clinicals, and then the fourth year is more of the elective.
And when you say clinical, in my mind, that means that you're working in a hospital,
right,
probably.
Or an office. Like you have to get your core rotations: internal medicine, pediatrics, family medicine, surgery, obstetrics, and gynecology.
So they're just rotating you around so you can get a good glimpse of everything, more or less to figure out which way you want to go after that, or
also because everybody should know it, right? It's like really the basics, and it is while you're doing that, you start to kind of get a feel for, okay, I want to go. The dichotomy really goes: am I going to be medical or am I going to be surgical? And there's a big difference between being a medical doctor and a surgical doctor.
Well, what is that? That's interesting. Obviously, surgery, you're doing surgery.
Right.
But like, what would medical, just everything else?
No, I mean, so medical would be more like diagnosis and management of diseases, and surgical would be more like procedural, So like, for example, in an emergency setting, right, you come in, it's abdominal pain, I work you up, I find out you have appendicitis, but then at that point, I'm passing you off to the surgical team they're going to fix the problem, But sometimes you come in and you have diverticulitis, it's not a surgical issue, stays on the medical team, you'll be admitted for antibiotics or go home with antibiotics, depending on how things are going.
Right.
So it's, I had a really great general surgery preceptor when I was in medical school, and I don't know, I guess I shouldn't use any foul language, but he told me like, hey, when it really hits the fan, you're going to call a surgeon. And that was kind of his pitch.
So there's a little ego thing there is what you're saying.
Oh, I mean, well-deserved, well-deserved. I mean, like you have to have utmost confidence in yourself to go into that room and try to fix that problem. I have a lot of respect for our surgical colleagues.
Well, I mean, we all do, man. When you put that gas on and you forget about what's happening, you hope they know what they're doing.
Yeah, they're very skilled, and they go through a lot of training. Their residencies are longer typically than the medical, unless you're specialized. But like, for example, family practice was 3 years, but a general surgeon, even just basic general surgery, is 5 years.
Wow.
Before they're fully independent.
And did you ever think about being a surgeon, or you knew that you didn't want to do that?
When I had first started, and I had the opportunity to shadow one when I was a first year, and I was like, this is really cool, but it's not for me.
Right.
Yeah.
You knew right then.
Right. The first week.
Interesting.
I really enjoyed it. I actually had a lot of great exposure to the operating room when I was in medical school, but I just kind of knew it wasn't my forte.
Because a surgeon, like, kind of going back to what you said about, working with people and helping with their problems. Yes, the surgeon does that, but I'm thinking more of a specialist, like, boom, come in and do it and I'm out. You're for the long term, more or less.
Yeah, I'm kind of more of your preventative, like mitigating symptoms, improving life, like quality of life kind of thing. But I mean, when something is wrong, you got to call the surgeon and fix the problem, right?
Right.
And my job is to try to keep you from getting to that point, or at least identify when that point is early enough that it's not a big problem.
Interesting.
Just for example, with cardiovascular surgeons, right? I mean, they save lives every day doing coronary bypasses, heart attacks, things like that. But if I had my way, you'd never be on that table.
Right.
And they would like that.
Right.
They would prefer that. They got other things to do, right? So kind of from the primary care standpoint, I'm trying to get patients in super early so I can say, okay, what are your risk factors? What are our modifiable risk factors? Some of them you can't control. It's, my dad and my mom, they all had heart attacks. Mm-hmm. You can't control that, right? That's genetics. But if we can get a little bit of weight loss, or we can stop some bad habits that might be promoting the heart disease, hopefully you never end up on that table with the cardiovascular surgeon.
That's ideal.
Yeah.
So first year of medical school, you figure out you're not going to be a surgeon. You want to go the other direction.
Yeah.
So are the days just like, I just envision, we've all seen the movies, but like it's literally just school, study, sleep, school, study, sleep. Like is there no time for anything else really?
You make time for mental health. The first couple years are pretty intense, and they have to be. It's just such a large volume.
Is there a big fallout rate of people that
are No, they're very selective about who they bring in.
So you pretty much know.
I think maybe in my class of 122 people maybe didn't make it to the end, and I think one was a family issue. It wasn't even academic.
Interesting.
Yeah, and I'm not sure, because I wasn't, I don't know all the details, but the dropout, they do not want you to drop out.
Right.
They want you there, which is why they're very selective about who they bring in. They want you to do what's called the match, where you get your residency program. They want you to get the match you want. They want you to pass the tests on the first time. And that's part of the whole process of applying, is like they really want to pick the best candidates. And it's not necessarily always the person who has this 4.0 GPA and the high score. Like they're looking for people that are more well-rounded and have life experiences and might handle the stresses better. Mm-hmm. Once you get into residency, it's even more stressful.
Oh, I would think so.
So really the first 2 years, it's a lot of just go to lectures, hit the books after lectures. You do start to have to pick what we call high yield stuff when it comes down to test time. You're not going to be able to cover every single thing. So you kind of got to look at, what's the most important stuff for me to cover, and then kind of triage, your study habits. And it's funny. I used to say, I'm sure there's smarter colleagues than me that didn't feel this way, but when I hit about my second year of practice and residency, all that stuff in the first 2 years started to click.
Interesting.
I was like, oh wow, I get why this disease
I
process
was reading this
presents this way.
So I'm assuming you have a very good memory. I would think that would be a prerequisite.
Not necessarily. I think you just have to play to your strengths. I am one of those few people that has like a really, really intense memory. Mm-hmm. I had some times in my practice during the pandemic when I lost it. It was really notable, right? Mm-hmm. And it was a burnout. But there are people that if you kind of learn your study habits, which most people in medical school have, you just got to play to your strengths. Some people are visual learners, some people are audio learners, and some people, they have to write it down or do things to remember them. And it's all about finding that.
Interesting.
Yeah, I remember my first semester, I went from being like a straight A student. I took my first anatomy test. I got like a 78. And I was like, what? What happened? Right?
78, man. Yeah. There's some people that are happy to get a 78.
Oh, no, I was devastated. And what I had done is I was a musician in college. So I was always up super late. Right. And, undergraduate for most medical students is pretty, I don't want to say easy, but compared to our peers, like most of us, we could walk into a test and do fine, right? And when you get to medical school, that's not the case anymore, mm-hmm. at least not unless you're like at the top 1%, right? Mm-hmm. And I tried to change everything about myself. I was like, I'm not going to stay up late anymore. I'm going to go to sleep at a certain time. I'm going to study at a certain time. And it didn't stick, right? And then I figured out that my best focus was 9 p.m. to 12 a.m. So as long as I studied from those hours every day and I was really consistent about it and then slept 12 to 6, like my grades came back up.
Interesting.
And it was just, that's just who I am.
Because that's not, I don't know the word normal, but like that would be contradictory to what a lot of people would say. Like that's not a very efficient time, but just like you say, play to your strengths,
For me, it's the time I'm on, even if it's just my sleep-wake cycle. Everybody has their own circadian rhythm. Mm-hmm. I can have only slept 4 hours the night before. It's very difficult for me to get to sleep before midnight.
Interesting.
It's just who I am. Yeah. But there's other people that they got to be in bed as soon as that sun goes down.
Right.
But then they're up at the crack of dawn.
Right.
It's just how we're different.
Well, when you started medical school and you show up to your class, is it most people coming out of undergraduate that are your age, younger, or is it more on the older side where people are coming back, or what's kind of the mix? It
was a pretty diverse mix. The majority would be people like myself that had gotten an undergraduate mm-hmm. degree. They were in their early 20s and now were matriculating into medical school, graduate school. Some of them had graduate degrees. I remember there was a couple in my class that had MPHs from Johns Hopkins. It was pretty impressive. and they were a little bit older. There was an RN in my class.
Okay.
Katie, I remember her. She was awesome. Yeah, and then there were people that I remember. I think there was a chiropractor in my class that had like left his practice to enter medical school.
Interesting.
So he was in his 30s. And there was some, I think the oldest might have been in the early 40s. But
do you stay with this group for 4 years pretty much? So you get to know most of them, right?
Yeah, you get to know them pretty well.
Right.
We do kind of splinter off. FSU's a little different. When we get to our third and fourth years, they have satellite campuses throughout the state, and we split into 6 groups of 20.
Interesting.
So really that group of 20 is the one that I got the closest with.
Right,
Yeah,
of
and
course.
know them really well. But yeah, you kind of get to know your peers pretty close, and you're studying together all the time. And
So when you said something about top 1%, like, so is there a group in that 120 that you're just like, oh my God?
Yeah, there's always somebody. Yeah, like there's nothing more humbling than being in a group of valedictorians where
Right.
you thought you were good, and you just meet a girl that like got a perfect score on the MCAT, and like and like they're just so chill about it, right?
Right.
It's like they're just on a different wavelength.
Is it because it comes easy to them, or do they still work hard and study? Like, is it just they're just so much different level on brains?
I think there are people that are just one of my professors. I'll just give an example. I had a rare condition in residency. I ended up seeing one of my professors to get diagnosed.
Interesting.
And he, I had seen like 5 or 6 specialists before I got to him. Right. And everybody was telling me different things. And like, I was a physician too. So I'm like, this doesn't make sense. I'm like, I get to him and he, he looks at me and he's like, hey, how you doing, Corey, my boy? Like slaps me on the shoulder and kind of grabs my head, takes an old fashioned, ophthalmoscope, looks in my eye. He goes, oh yeah, I wrote a paper on this in 1988. This is fun. And he starts talking about it. And he starts talking about how photons have some kind of negative charge that go across the optic nerve. And it goes into this deep physics about it. I can't remember a word he said. It's just like, it was just completely over my head.
After you'd been to multiple specialists, you're a doctor yourself, and then he swoops in with this.
And he was like, I wrote this paper, like I know exactly what you have. And he was 100% correct.
That is wild.
He was so basically I had gone like partially blind in one eye.
Wow.
And it was, nobody could figure out what it was. My optic disc was swollen. So everybody panicked because sometimes that can mean bad things.
Right.
And he was like, it's from some virus you had and it'll go away in a couple of years. Right. And his recommendation was so strong that when I got my disability insurance, you have to mention everything. Right. I thought, oh, for sure they'll put a writer for blindness or something, right? No, they just contacted him and they didn't put any writer at all. Like I was like, wow, like his note was so, and he was right. It took about 2 years, it went away, and
not only did he write the paper, but he had the confidence to just diaggnose it. Like, I know what it is.
Just like that. I mean, he had a lot of data in front of him at that point. I had done a ton of testing before I got to him, but. Everybody else was having me do like laser scans and like all these fancy, and he was just, just with handheld devices. Oh, that's interesting. It is, but that's my example of somebody who, this guy is, I'm never going to get it. Like he's above.
Right.
Yeah.
Right. That's a good point. It kind of makes me think of, the word on the street is AI these days. Like AI is going to do this, AI is going to do that. But those are the kind of things you hear. Well, that's just the human that is inquantifiable a little bit. You know what I mean?
I think the clinical gestalt is invaluable, and I kind of pride myself on it too. I mean, and that's why training is what it is. That's why the residency hours are so long. You have to be exposed to 25,000 cases, 100,000 cases for it to stick, so that when that 1 in a million person is in front of you, you don't miss it, and the only way to do that is to get exposed to it. And like, you have to get all that exposure. I think AI is going to be in medicine. It's going to be an extremely useful tool to correlate data and look at patterns and help you see the patterns that are there. But ultimately, the person kind of putting it together should be the physician on the other end.
For sure.
For radiologists, for example, it could highlight things on an X-ray. Be like, hey, what do you think about this over here? Oh, look at this density behind the heart, cardiac, and then the radiologist might look at it a little bit harder, and it's going to make them more efficient. It's going to mitigate some of the fatigue that they might be feeling after reading 200 X-rays that day.
Right.
One of the really useful things that's really amazing with AI, I don't personally use this, but I know some colleagues that do, is the AI scribes, where you can go into an exam room and put your laptop down, put the microphone on, and it listens to the conversation and it just fills the note out.
That's nice.
It does the entire history. It listens to the patient, listens to the doctor, and you could just call it the exam findings, and it just
so much more efficient. And then, we use it in our business a lot for meetings, and like just the ability of absorbing the whole meeting and summarize it, and then keep history, and then being able to correlate. Oh, well, you remember you said this 6 months ago, and like it's like invaluable. It's amazing.
I remember, I was a first year resident when they were kind of rolling out the meaningful use electronic medical record stuff. So like we kind of had half of our stuff on the computer and half on the paper charts, right? And you'd have to go get the stack of charts and like, well, what was their kidney function last year? What was it the year before that? What was it the year before that? Did they have an echocardiogram 6 years ago? Let me pull through this chart, right? And now it's all on the computer, but it's kind of like you're doing it, this data mining. You really have to go, and there's lots of systems. So in my practice, I might have to log into the Baptist portal and look over here, or maybe I'll go over to Precision and I'll look up this, and just trying to find the data so I can make a decision for the patient. And I think eventually, once we have these like national systems, which are being built, Epic is really amazing on this.
Great to hear.
And, you'll be able to go, hey, give me my patient's glomerular filtration rate over the past 10 years, and it'll go, oh, here you go, boom, and then you'd see it, and you can make an educated decision quickly.
Right there, so much more efficient. That's amazing.
Yeah.
So the first 2 years you go through, and then you start your clinical. So what were you doing there? Were you in that small group? Did you stay in Tallahassee, or?
I went to Fort Pierce, Florida.
Okay.
Which was awesome.
So an ER there, or what? Was it?
So when you're doing your third year, you're in Florida State. You're in a group of 20, and you have to do what's called core clinicals, and those are different for everybody. So it's pediatrics, internal medicine, general surgery, obstetrics and gynecology. I believe emergency medicine is one of them. I might be forgetting one, but I remember I started pediatrics, and it was mostly outpatient. We did 6 weeks of outpatient and 2 weeks of inpatient, and it was you get thrown in the deep end. It's kind of like here you go see some patients. Tell me what you think. When
you say outpatient, literally you're going out to see them.
No, like in an outpatient office.
Oh, okay. Yeah. Just like a regular office versus.
So outpatient meaning like not in a hospital.
Got you.
Yeah. And then inpatient would be like the kids that are in the hospital. Yeah. So.
Well, kind of goes back to where you started. You started working with the kids.
Yeah, that's true. That's really true. I always enjoyed pediatrics, and I flirted with applying to pediatrics for a while, but I also really enjoyed like internal medicine and geriatrics. Right. So that's why ultimately I chose family practice. I got to do all of it.
Do it all.
Yeah. And it's you start getting exposed to like the patients in the clinical setting and seeing real pathology. I remember one of the hardest things I had in my first rotation was I could not see the kids' eardrums. Like one of the most basic things that doctors do, right? Look in an ear, and I'm great at it now, but like that was like my whole goal for the first 2 weeks. I'm like, I just want to see ear infections come in like 3-4 times a day,
right?
To those offices. So. Yeah. And you can't see it. It's like, you're just going to throw antibiotics at the kid that says his ear hurts every time. It's not good practice.
Right.
Yeah. So yeah, I mean, I remember that very clearly. Just
interesting.
I was just making sure that I could examine these ears,
right?
Before I moved on to the next thing.
Yeah, that's for sure. So fourth year, what are you doing on the fourth year?
Fourth year is like you're doing advanced course, so it's like shorter version. So, for example, you would do like advanced internal medicine, which is like a really more intense hospital rotation, and you'd have more responsibilities. One of the great things about Fort Pierce for Florida State is there's no teaching hospital. At least there weren't then. There are no teaching hospitals out there. So you kind of got treated as a resident a little bit, where the attending physicians were like letting me evaluate the patients side by side and put in orders and like real practical hands-on experience, And I did like you do like an advanced internal medicine, advanced pediatrics, and then you get more electives, So that's where you kind of get the time to, okay, I really think I might want to do oncology, or I might want to do oncology, or what am I thinking of?
Right.
What I'm saying? Yeah, like get into specialties, and you get to also do externships where you might go to another university or another academic institution for a few weeks.
Okay,
and those are fun to take advantage of too, because there really is differences between academic institutions.
Sure.
And you learn a lot when you.
Did you ever have a patient freak out, like, I don't want a student to work on me kind of thing?
I was really lucky with that. The only time I can think of as a student that I had a patient say, I don't want the student in the room was a woman of a faith that didn't want men to, and it was an OBGYN rotation.
Got it.
Well, so it wasn't a personal thing. Yeah.
Right. Okay.
I did have some colleagues that like they suffered from that a little more.
Yeah.
I think it's maybe how you like kind of present yourself, like I'm not sure, but no, that really didn't come up much.
Well, I just know any experience I've had, like, I mean, we want the next person to learn. I mean, let's go,
Yeah. And I think I always tried to make sure I represented myself, as a student, not as, you look very official, you get the white coat, and we had long coats too. Like used to only the attending physicians used to have the long coats, but Florida State was like, you're all getting long coats. And we had like these gold badges and like little pins and, stethoscope and like, you just look like a young doctor.
Yeah.
They were really up and like you had to be shirt and tie, like you look very official.
Right,
I mean, even sometimes more official than the residents who are like burned out and like wearing scrubs, right?
Well, I like the scrubs, man. I feel like it just kind of loosens things up a little bit, It's not so official.
Yeah, I think it's kind of become the official uniform. I mean, I barely wore the white coat the last 5 years of my practice, and I have one. You kind of think about, especially during the pandemic, it does. You got long sleeves. You can't wash your arms, and you don't want to spread things around. And so in a sense, it's more of a practical uniform. When I started this new practice, I was like, oh, I'm gonna dress. I wore a suit and a tie all the time, and I kind of got the vibe that maybe people thought it was a little stuffy. I just went back. I'm like, all right, I'm gonna go back to wearing scrubs.
Like it's hard to block and tackle whenever you have a full suit on.
We'll get back to the story in just a second, but while you're listening, here's something you should know if you live in Northeast Florida. If you're self-employed and trying to buy a home, it's not as hard as you might think. We work with business owners, freelancers, and creatives every single day. People who don't fit the traditional housing mold, and we're here to let you know that we have real loan programs that make homeownership possible. We've helped tons of local business owners and creatives get approved using flexible loan options that work for them and their business. First Coast Mortgage Funding is proud to sponsor Hometown Jax right here in Jacksonville.
So fourth year, you go through that, and then you graduate, and then what happens after that?
So there's a day in March, I believe it's March 15th, it's called Match Day.
Okay.
So basically, end of third year, you take what's called USMLE Step 2. There's two parts to that. They might have consolidated it, but back then it used to be two parts. There's a written exam, similar to Step 1, and then there's a practical skills exam, which is only given, I believe, Atlanta and Georgia, maybe a couple other places. So you have to fly out to do that. And if you pass that, then you can start to apply for residencies.
Okay.
And those are your training programs. And you pick the residencies based on what you want to do. So like if you wanted to go into family medicine, you would apply to family medicine. If you want to do emergency medicine, they have like a different application service. And you apply to the places you want to go. And then hopefully you get interviews there during your fourth year. And you kind of arrange those. Then you do your interviews. You pick 10 or 12 or 20, however many you can get in there.
Right.
And you would do what's called a rank list, right? And they do a rank list, right? You pick 1 to 10 or 1 to 20 or however many you want. What programs I want to go to, starting with, I want to go to this one. After that, if I can't get in there, I want to go here, and so on and so forth. And they do the same thing with the students. And there's a computer program that matches it all together. And on March 15th, match day, the whole school comes together and get in the auditorium, and you go up on stage and they hand you an envelope.
Interesting.
And you open an envelope and it tells you where you're going.
That's a little stressful moment there.
Yeah, it's also like a lot of joy for people too, because you're very, there's people that want to match at certain places. There are certain specialties that are difficult to get into, and they work very hard to get there. And that moment when they're like, "Oh man, I'm getting into ENT," I never thought I'd get there. Like there's so much like joy. It's even more joy than seeing somebody graduate. Match day was just crazy.
So where did you match up to?
I matched to Tallahassee Memorial Hospital.
And that's when you're in the ER?
That was a family practice program. Okay. And that was my number one choice. They were really awesome. Like it was what we call an unopposed program. Like a lot of times in family practice, you like to go somewhere where there's not other residencies because you get to do everything, right? And really great training I had there. And practiced Tallahassee for a bit, finished residency there. And I actually got a colleague, former resident there I was friends with, that was a year ahead of me, came out to Jacksonville to work for, basically in the Baptist ER and the Flagler ER, which is kind of an interesting, they have a multidisciplinary approach where like in the ER at Baptist, it's, there's ER guys, but then there's family practice and pediatricians together. And like, we kind of like divide the patients as appropriate, and they were working out here. They really loved it. And I didn't really know where to go Like, and I was like, oh, I'll go interview, and met the group. They were really awesome, super nice. And the CEO at the time was kind of, his thing was like, we believe that every patient that comes in at the ER deserves to see a physician. And, like, I like that tagline. And he was a really nice guy. Dr. Rick Stromberg, just retired a couple of years ago, actually. But he was always in the trenches with us. He's a great guy. Yeah. And, it was a good experience. A lot of stuff that comes into the emergency room is urgent, but yet not critical, right? So having the intern, like the family practice and the pediatricians, like really helps kind of take the burden off the guys that are handling the major heart attacks, the strokes, and major injuries, and they have the experience from their training to do that. So it's kind of nice to take the load off.
Do you remember the first patient or two that you were completely on your own? Like, I'm a full doctor, this is my first patient, without anybody supervising me? Well,
that actually would probably go back to residency, because I used to moonlight on residency at urgent cares. And I think one of the ones that sticks out the most, when I was moonlighting as like a second year, I had a lady that tripped in a hole and came into an urgent care at like 9 o'clock. And she had such a severe ankle fracture. It was like completely destroyed, like misplaced. This is one of those, like, this is going to the operating room. She somehow dragged herself in to an urgent care. And that urgent care was hooked up to the hospital. So like, I got her back and I x-rayed it, and I called the orthopedic surgeon on call, and he was like, she came in, she walked in. I was like, yeah, I swear. And he's like, well, I mean, it's actually a decent alignment, and like her vessels are working. And he's like, I could probably just see her in office in the morning if you split it up. I'm like, okay. But I was just, at the time, I was like freaked out about it. I was like, oh, well, she had what's called a triballeolar fracture, where like all three parts of the ankle are broken. Okay. And that's almost always surgical. Most ankle fractures are just like, one part, and you just put a splint and send them home on some crutches. It's usually not that big of a deal.
So it was a serious hole she fell into.
She really did a number. People have continuously impressed me about how tough they are.
Right.
And I've had patients walk in with like a broken hip, and they walk in and get on the stretcher, and then you do the x-ray, and like the hips. I'm like, how did you put weight on that? It's supposed to be one of the most painful things.
Right. Excruciating, I'm sure.
Yeah, but they did. I saw them do it.
Yeah.
People come in with like major heart attacks, so they're worried about their family at home, and they're like, I got to go home and take care of XYZ. And I'm like, you're having a major heart attack.
It's interesting. It's probably a tale in human condition. Like, if your brain really controls a lot about how everything else is working, I would say.
I always said medicine's a lot like left field. It's most of the time people are fine, but if that ball comes your way, everybody's looking at you, and you better not drop it.
Right, exactly.
It really is like that. Like, things sneak up on you, and that's where all that experience comes from. It's like, I saw somebody talking yesterday about like, why do they make residents work such long hours? And like, they've gone back and forth on that, but really what it comes down to is like, they've kind of proven that a tired doctor that knows the patient is probably going to do better than passing the patient off over and over and over.
Yeah.
And a lot of the medical errors happen when you pass things off.
Right, for sure.
Yeah. And it's, you just kind of have to get exposed to everything, so that when it shows up in front of you, you go, okay, I've seen this.
For sure.
Yeah.
Well, I imagine being in a hospital like that, like, you've seen some pretty serious stuff. Like, gunshots, knife wounds, like car accidents, all that stuff.
Yeah. I mean, Baptist is not a trauma center. So luckily I didn't get too much trauma. I did a lot of shifts up on the north side, and occasionally gunshots would come through the front door.
Right. As
a family practice guy, I'm not the one handling that. I might be an adjunct as an assistant, but the ER guys are going to take over those.
Right.
I think more of the caution is the people that seemingly look okay, but they're actually really sick.
Right.
One that comes to mind, I had a grandmother brought in like 3 kids and herself, and she checked herself in.
Okay.
And the kids had like the sniffles, and then she kind of just said, "Oh, I think I have the same thing," right? And the kids were all fine. Like, they had a cold, like, so I had checked the kids first because she was really insistent on it. I get to her, and I'm looking at her, and she's like really pale, and I'm like, "What's going on?" She's like, "Well, I've had like menses for a couple months," and I'm like, "Oh, let's get some blood." And like, she had like almost no blood, like she needed like an emergent transfusion.
Really?
Yeah. And, she was just downplaying it. She was like, "Oh, take care of the kids first." Right.
Right.
And that's the kind of thing I'm talking about. It would be really easy to kind of go, "Oh, she must have the same cold as them." Her vital signs weren't that abnormal.
Right.
Right. She maybe had like 105 heart rate, nothing that would make you raise alarms. Right. And, you just kind of got to pay attention to those kind of people, those stoic people, because sometimes
Is testing the blood kind of the catch-all? Like literally,
Not
can you
necessarily.
see most everything of a blood test? And like, I always wonder when you do the blood test, why don't they just do everything? Why does it always have to be, well, it's just going in for this test? Is it just expense or what?
No, not necessarily. Some of it is expensive. That's a nuanced question. There's so many things that you could test
Got it.
that if you were to do everything, you would end up with so much data, and then you would start chasing these little bits of data that may not have anything to do with what's going on. And that's where like it kind of comes down to, like, you got to treat the patient, not the number.
Right.
Like look at the patient, look at the vital signs, look at what's going on, what they're telling you. And then you try to order things that are going to back up or confirm or deny things that you're worried about.
Right.
So for example, if you were to come in and you were like, I'm having chest pain, right? And my dad had a heart attack when he was my age. And, I'm really worried I'm going to have a heart attack. You might do an EKG, and like a lot of times you get what's called a non-specific reading. Like it's not obviously a heart attack, but it's not completely normal.
Right.
Right. And you do the blood work, right? And blood work's fine, right? Well, then the question is, well, where do we go from here?
Right.
Right. So sometimes the blood work on a heart attack take a couple hours to show up, right? Sometimes you get what, like a result that's in the gray zone, and you kind of have to risk stratify. Like if you get a gray zone result, it's like, okay, who's safe to go home and see a cardiologist next week? Who needs to come in tonight? And which inconveniences the patient, right? A lot of patients, they don't want to go to the hospital. So like and you can potentially subject people to dangerous testing. Like for example, a lot of people, why don't you just take them to the cath lab, see what their arteries look like? Well, it's like, it's the radiation, the dye, you could puncture the artery.
Right.
And even doing a stress test, like if they have like a narrow artery that you're not aware of and you put them on the treadmill, like that might cause the heart attack.
Interesting.
So like you got to be selective.
I never
what
really
you
thought
look
about
for.
it like that, because you think from the layman's point of view, just throw the
test
blood
it.
in there and test for
Yeah.
everything. Well, that probably makes it worse. There's way too much to quantify there.
That comes up a lot. There's a new emerging field of medicine called precision medicine, and there's a lot of these genetic tests, right, that they kind of look for genetic markers. And the argument against that right now is like, yeah, we can test for these things, but we may not necessarily know what they mean clinically, right? You can have a mutation that has no effect on your life.
Right. And why start treating something that has no effect?
And it could cause a lot of distress for the person to know that they have that.
Yeah.
Yeah. And they may lead them down a path that's worse than when they started.
That's really interesting discussion. I didn't think about that. Because we go back to the mental part of the human condition.
Yeah.
I may not want to know I have that gene, especially if nothing's happening.
Yeah. I think as these tests are more recognized and there's more data, like they'll become more useful. I mean, it's Breast Cancer Awareness Month. So like one of the great examples would be the BRCA gene, right? So like if you have a female family member or a male family member who had breast cancer at a young age, I would recommend getting the test for that gene, because if you have that gene positive, you want to start your screenings very early.
Right.
You want to do MRIs, and you may, in some cases, may even want to do prophylactic surgery to prevent cancer. So like if I had a woman who was 18 years old and she was BRCA positive, she wanted to have children, I would advise her to have those children very young.
Right.
Interesting. And then consider having prophylactic surgery or just doing other measures to mitigate the risk of breast cancer as she aged.
Right.
But like if she waited till she was 25 and she developed breast cancer, she's too
late.
So we have some genetic markers that are critical, right? But we just don't know enough about all the different ones that are out there.
Right.
So for some people, they can be hugely beneficial. Like if you have, it's just a little controversial right now because it's still kind of an emerging field. So that's just a great example of like testing. It's like there's some routine tests. Like nobody would argue for me to get like a complete blood count once a year on a patient. It may be unnecessary in a healthy patient with no symptoms, but it's one of those things. It's a basic test, right?
And you can measure off of it. A word that I did write down is bedside manner. You strike me as somebody that has good bedside manner, because the way you say your interest kind of started, I can tell by your personality, because I just think that's really important, especially when you're talking to a patient, of kind of just making them feel comfortable in a short period of time on explaining whatever it is.
I think bedside manner is crucial.
Is that something they teach, the psychology of that in medical school?
Florida State did do lectures on something called motivational interviewing, which is kind of like, how do you get somebody to open? Like one of the things that's really frequent in medicine is, You come in, you're like, you're having chest pain, right? I go, when did it start? Okay. Does it feel sharp? Yeah. No. Yeah. Okay. You having trouble breathing? Yeah. That's a closed question, right? It's yes. But like, if you really just let the person talk to you and say, "Are you having chest pain?" Like, tell me, how does that feel? You know, like, what does that feel like to you? Like, when does this get started?
Instead of giving them the answer,
they're gonna tell you what's going on,
right?
And there were like all these studies that showed that the average physician interrupts the patient within like 10 seconds of like walking in the room. It's like a person sits down. It's like, "Hey, Mrs. Smith, how you doing today?" "Oh, thanks, doctor. You know, I'm really concerned about my knee." "Oh, wow. Okay. Well, anyway, let's take a look at that." And like, they just didn't even let him tell him what's going on. And it may seem something simple, like back pain, for example, usually just musculoskeletal, but like, hey, they could have an aneurysm. They could have some kind of spinal cord lesion.
Interesting.
And if you let them talk for a second, they'll tell you that. They'll tell you
such a big responsibility that you have. You never know what path you're going to go down.
It is an awesome responsibility. It is a privilege.
Right.
There's not a lot of opportunities in the world to kind of bring positivity. And I just think that whenever we get a chance, like uniquely as physicians, we get a chance to kind of just make people's lives better.
Well, I think, perception is doctors make a lot of money, and I've always thought, well, they should make a lot of money, but regardless, man, I can't imagine doctors doing it for the money. Like, it's just, you've got to have an intrinsic urge to help people, like, because the money would not last. There's no way.
I mean, there are some specialties that make more than I do, but like the money doesn't buy it. Yeah. No. Like, you have to enjoy it.
Right.
And I think it's important to remember that too. I remember there was a moment during the pandemic. I think it was during the Delta wave. I was working with a friend of mine who he unfortunately later passed. But,
sorry.
We were sitting there and like when there's a cardiac arrest.
Were you down in Baptist here during?
I don't know if I should say. I don't know if they're going to get upset with me.
Oh, okay.
But yeah, I was.
Got it.
I was at Baptist South that day, and we were sitting in the pod together and seeing patients as they came through, and there was, whenever there's a cardiac arrest, they call it code blue room, whatever, code blue room, whatever, right? And it was going off like every 5 minutes. I mean, like every 5 minutes, code blue, code blue, code blue. And
because
it was
of
just
people coming in with severe
pandemic. It was like all over the hospital. I mean, like we were just overwhelmed, and there was just so much severe illness. And there was a moment when it felt really futile, you know? And I said, I don't want to say his name, but like,
of course not.
I go, I think we chose the wrong profession. I said it to him, right? Because I was just burned out.
Yeah.
And he goes, no. He goes, no, we didn't. He goes, what do you want to do? Be in Wall Street right now? You know? Like, and not that there's anything wrong with that, but like, and he said to me, he's like, at least we have the chance to bring some light into the world, makes a difference for some people.
For sure.
And then he got up and he went to the code. Like, I'm just sitting here pitying myself. These people are sick, right? And I'm fine, but I'm just the physician, right? And like, and he had it harder than me, and he got up and did his job, and he was right, man. It's like it gets easy in the modern medical system and to get frustrated with it, and it really is like a maze, and it doesn't have to be that complicated. And I think, I've had great preceptors in my career. I had great residency directors that they're like, the patient should never be the enemy. Like, if you ever feel that way, you need to take a step back and kind of reevaluate.
Interesting. The patient should never be the enemy. Yeah, that's an interesting statement.
Yeah, I mean, sometimes it's like you can get people that are in difficult walks of life that are really argumentative and difficult to work with, and it's easy to start to put it back on them, right? Get frustrated and go, why did you, but really, like, if you just kind of take a step back and look at it from their perspective, they're in a vulnerable position. They're feeling pain. They're feeling this. They're feeling the other thing. Like, it's, you should objectify yourself a little bit and kind of just try to see where it's coming from.
Oh, absolutely. That's great. That's great. Well, I did want to hit on what you're doing now is, and I think this is the right word, concierge medicine.
Yeah, that's the more common term.
But it's kind of it's a newer trend. It's been going on for a while, but I personally use something like that, and I've just been amazed by it. I think it's amazing. So talk about a little bit what you're doing with that, like in the purpose and all the details.
So it's really just kind of trying to get primary care back to its roots of being patient-centric. More traditionally it's called concierge, but like there's been a trend to rename it as a direct primary care. There's also like direct cardiology. There's lots of direct services, and direct just means direct to consumer. Like you're not going through the insurance, right? I kind of started doing this in 2020, not as an official practice, but everything was locked down. People couldn't see their physicians, and I'd get calls from friends, neighbors that were like, "Hey,
interesting.
I think I'm sick, or I'm having this. I can't get into my doc. I don't know what to do." So I actually just started going to their house. Like I'd be like, "Oh, I'll go check you out." Right. And I didn't really have a practice set up then, but I have a license, right? So
right.
I did that a little bit, and like towards the middle of the pandemic, I was like, I actually really enjoy this, and it's really nice to be able to see people in these settings, and maybe I should do this full time.
Right.
Then the pandemic went nuts, and it was like 2.5 years of just working shifts like crazy.
I'm
right?
sure.
Coming through the end of it, at the end of 23, I was like, okay, now it's time to give this a shot, and I launched officially in I think it was July of 24.
So the model is that they pay you a monthly fee, and you are basically there, 7 days a week, more or less, to help, be the first line of communication.
Yep. Basically, it's a membership model, and that's it. Like the flat rate covers me. I don't collect copays. I don't limit the number of visits. I don't limit the phone calls. It's open access, right? And it's really about the communication, and it's kind of nice. I like to communicate with my patients freely too, and I didn't like the feeling of when I first started. I actually wasn't fully direct. I was trying to bill insurances, but it kind of like trying to chase this or think about, I can bill for this, or I can upcharge this, or I can, like they talk about that a lot in medicine. It's like, well, you can bill this as a level 4, or you can charge because you talked about XYZ. And I'm like, it's like you're kind of chasing the money more than caring about the patient.
Well, I think it's okay to make the money, but it becomes very complicated on your end too. It's like you chain it like a standard fee every month, and I mean, tell me if I'm wrong. I mean, the one I use is just great because it's almost like that advisor that knows, and then you need to come in, we need to do blood work, and then you need to go here. You know what I mean? The first line of people.
Yeah, I mean, and it's just really nice because I get to sit down there's no rush. Basically, the way to break it down is like in a traditional practice setting, you have to carry a panel of about 2,000 patients or more.
Wow.
To keep the appointments full, because you only get paid when you see the patient. Right. And when there's that many patients, and you do get to know them very well, but you don't get a lot of time with them because spending more time with one person means you maybe snubbed another person, or a person's waiting an hour to see you. And it happens, you run behind because things come up that you don't expect, and you have to address it. But in the direct care model, I have hour-long appointments or more. I can schedule what's needed because I'm not worried about filling every slot. Like I'm getting a set amount per month, and I don't, I do what's needed for the patient at the time. There's a patient I've seen 3 times this week, because they have an illness. And, it's kind of funny. Like I've seen them in their house, and they're like, "Oh, I didn't mean to take up." So I'm like, "No, I mean, this is what I'm here for." And the whole goal is to keep you out of the hospital. And
Well, I just know with mine, just the simple being able to shoot them a text, hey, this is what the situation is, and just get a response. And it may not even be anything complicated, but if you went through the normal medical channels, that would be a month-long process versus just boom, this is what I think,
I saw so much of that in the ER. I remember one really clear example. I was working over in Orange Park, and I had a woman come in with really severe dizziness. It had been going on for a week. And by the time she come in, she's so dizzy and she's throwing up everywhere. And she can't. So I'm like, I got to work you for a stroke, right? And it's not that I mind doing the workup, but to that patient, that's 3 CAT scans, right? That's a lot of radiation. And once you get a certain amount of CAT scans in your life, it does increase your risk for cancers, right? So we try not to do a CAT scan if you can avoid it. And at the end of the day, they were fine. And she ended up having vertigo, and you treat the vertigo and she's fine. But she had told me, she's like, I tried to get into my primary. I just couldn't. I bet the doctor's probably a quality doctor. If she could have gotten in on the first day, he probably would have given her some meclizine and said, hey, if it's not getting better, go to the ER, which would have been the right thing to do. Right. And she probably would have been fine.
Right.
And it would have saved her 1,500 x-rays worth of radiation.
Time and effort. And I remember, because when you said, I'm a little bit older than you, but I do remember my mom taking us to the doctor, and it was just old school. Like, hey, I got a problem. I'm coming in. And I remember just sitting there writing a check, like when it was done. Like there was no insurance and all of that, which of course insurance has it's desperately needed in a lot of circumstances. But I just think it's so awesome. This new type of practice that's come up. I'm sure you're going to do amazing with it.
I hope so. It's really been great so far. I really enjoy it. It's just great to be able to sit down with the patients for like a longer periods of time and even schedule stuff. Cause I'm able to focus on more, movement, nutrition, mindfulness. We talk about mindfulness a lot, these are things that everybody wants to know to make their lives better. And it results in less prescriptions, less time in the hospital, like more prevention. You know? And it's just hard to do that in those 15-minute appointments. And just like kind of having that open.
You say that with a very funny straight face, like it's impossible in 15 minutes.
It is. It's hard to do it in an hour.
Right.
I saw somebody earlier this week, and we have a lot of health maintenance things to get through, and we started to kind of touch base on, nutrition, and we were getting into it. I'm like, hey, and I go to her, I said, we've already gone through a lot of information. I don't want to just like have it all drowned out. So I'm like, let's get all this done. And then once we'll come and we'll talk, and then like, we'll kind of meet monthly and we'll go over the nutrition. And it kind of awards you that in the medical setting now, like they're doing a pretty good job of trying to make sure that all the different like to have nutritionists involved, dietitians, and, they're like, oh, you can go over here and talk to them for free as part of our network. I know Baptist does something like that, but it's just for the patient too, that's time off work. And it's hard to get around to all these different appointments. And it's just the system as we've grown as a medical community. You can't compare the pharmacy in 1980 to now.
Right.
Like it's the amount of drugs and the amount of treatments and the amount
not even close.
Yeah. So as that's become more complex, it's kind of the system has grown and grown and grown, and that's where and that's kind of it's hard to navigate.
Oh,
it's hard to navigate, even if you know what you're doing. That's where primary care is so important, because you need to have that person in your corner that is helping you. What do I need to do, and what should I do? Prevention or treatment?
That's why I think this type of practice is so awesome. Well, I want to wrap it up here, and I really want to. Your story is so interesting. I love talking to you, Doctor. What advice would you have for somebody who's in high school and thinking, I want to be a doctor? How do they figure that out? What remember back to your days, like, what would be your advice to somebody thinking about doing it?
In a high school student, I would say, if you're thinking about, first of all, keep your grades up, right? So you can get into the university you want. Do some shadowing. Reach out to your local docs. Many of them are very happy to take you into the office and just say, hey, why don't you just spend a day with us and see if you like it? And all those, you can get exposed to see if it's something that you want to do, and like you said, it's not for the love of money. It really isn't. Like you have to enjoy medicine, and medicine is really a great career. I mean, it's not the practice of medicine that burns people out. It's everything else that comes with it. So you have to really love it. And if you do, it's worth it. I mean, if I went back in time, I'd do it again.
Yeah.
So I'd say for high school students, keep your grades up, make sure you don't develop any bad habits, do some shadowing, and then when you get to college, just kind of make sure you're getting those prereqs, hit the ground early with those good grades.
Is there certain schools, like you mentioned, the one you went to wasn't big on pre-med, but does that really make a big difference?
It does.
Pre-med, it does.
It does. I didn't know until I was in medical school.
Just the knowledge part of it.
Yeah, no, how, like, basically they do judge based on what university you're coming from. Like if you have a 4.0 coming from Duke, they're gonna be like, wow, this guy. But if you have a 4.0 coming from like my school, they're like, well, he only had 20 people in his class. Yeah. So it's not that they just dismissed me. It's just that it's like they do weigh the schools differently.
So pedigree and reputation still mean a big deal in the medical when it comes to academics.
Absolutely.
Okay.
Absolutely.
Interesting. That's very interesting. Well, good. This was a great discussion. I really appreciate you coming in. This is awesome. I know our viewers are going to love to hear straight from a doctor, and I wish you the best in your new practice. I'm sure you'll do great. Thank you very much,
Thank you so much.
Yeah,
it's good to be here.
Good to meet you. The Hometown Jax podcast is recorded and produced by First Coast Mortgage Funding, located in the heart of Jacksonville. Do you want to be our next guest? Visit our website at hometownjaxpodcast.com. We can't wait to hear your story.